Goodness.
Marion, where are you?
Where am I?
Yeah.
I'm in my office at the Department of Family Medicine.
Oh, I thought that building was closed.
It is?
But you have a key.
No, it's not a key. It's a pass card. Actually, the building is now open.
Okay.
But I have, I just enter the department. I break and enter every day.
There you go.
So on that note, now that I've divulged my criminal doings, why don't we welcome everyone to the workshop. So bienvenue à tous. I'm Marion Dove, as Dr. Talier has just pointed out, and I'm the chair of the Department of Family Medicine. I'm delighted to welcome such a large group of you here today to this workshop that is part of our Global Health series that is a joint collaborative effort between the Department of Family Medicine and the School of Population and Global Health. Elena Adams from the department was the one who initiated this series, and she started it in January. We have a monthly talk and a monthly workshop since January on the topic of on variety of topics in global health. And they have been very rich and stimulating for all members of the Department of Family Medicine. So I'm delighted to see you all here today for a fireside chat that will involve some of my old friends. So that is very exciting for me. It's unfortunate that we can't see each other in person, but the virtual world is second best. So it's nice to have this chance to chat with everybody. I want to encourage you all to follow the Department of Family Medicine on social media. We have lots of interesting events that you will hear about if you follow us on social media. So please go ahead and do that. And with that, I will turn the floor over to Elaine Adams, who will introduce our moderator today and our speakers.
Well, I don't know whether I'll introduce the speakers or not. I think Anne will do that, but this is a great pleasure of mine to introduce Anne, who will be facilitating this session. It's a little bit different than the prior workshops where we were going into small breakout groups and chatting informally, but hopefully we'll have the same informal opportunities to engage today as well. Anne I've known for a very long time. She's a public health physician and the founding director of CLEAR Collaboration. That's where I knew her first, which is a global effort which really tries to bring frontline workers into thinking and acting more on the social causes of poor health through patient care, referral, and advocacy for social change. And she's also been an innovator close by at the Multicaf, which is a food bank in the Côte-des-Neiges area, where she's used it as sort of a platform for community outreach and onboarding vulnerable and underserved community members into St. Mary's sort of family medicine sort of practice. So I think also a really, really important initiative connecting, again, people to services and allowing for whole person care. So on that note, Anne, I'll pass the baton to you.
Thank you very much. So it's my pleasure to introduce two speakers that we have joining us today. The first is Dr. Pierre Talier, who's an associate professor in family medicine at McGill. And Dr. Talier is currently leading a project that implements the first ever LGBTQ migrants, so immigrants and refugees, and racialized community health clinic and peer navigator outreach program in Montreal. And the goal is to increase access, improve continuity of care, and address the health impacts of COVID-19 on this population. It's integrated in a CLSC serving mostly migrants, and this project brings together an interdisciplinary team of healthcare providers, peer navigators, and LGBTQ migrant community organization, AGIR. As well, I'm also very pleased to welcome Dr. Juan Cherwin, who's a family physician who's been working on community health for many years via the CLSC Park extension. And many of the patients there are recently arrived immigrants and asylum seekers with significant language barriers, and the CLSC has used different ways of helping provide care across such barriers. And he has advised the establishment of the Collaboration Interprofessionnelle Montréalaise Étudiante, the CIM clinic, which is an interprofessional team of medical, nursing, diabetics, and social work students sharing the common dietetics and social work students sharing the common goal of diminishing healthcare gaps experienced by asylum seekers in Montreal. So this will be a very exciting hour together, because it'll be very interesting to see how do we make innovation in primary care on the front lines to serve the different needs of specific groups. So perhaps we'll start with Dr. Talier. Perhaps you could tell us a little bit about your work with this innovative clinic, how it came about, how you went about developing it, what were some of the challenges, and what you thought were some of the key factors that made this clinic happen, and hopefully to be an ongoing feature of the Montreal medical landscape. Thank you.
Thank you. So just to be clear and specific, though, I am for what you guess would be the appropriate thing, would be the clinical lead person on this project. The project is really not mine. It was presented to us by Edward Lee, who is a doctor of social work at Université de Montréal, who is also on the board of director of AGIA, which is a community organization that reaches out to immigrants and to asylum-seeking individuals, mostly Arabs, but also of variety of Spanish-speaking countries. And he came to visit the CLSC and speak to Vanya because he was enthralled by the Maison Bleue, which Vanya been a co-creator, and wanted to, and still wants to, establish something similar for the population that we're dealing with. I had long been working with young people who are GLBTQ at Head and Hands. And so for me, when I transferred to the CLSC, I brought a lot of that population with me. So that portion was something which I felt at ease with and could offer that service. So we learned, or I learned, because I happened to be on the foundation board of the College of Family Physicians, that there's a grant project that was starting around COVID. And so we applied and got the grant to start the project, which, as you mentioned, is an integrative approach to care, which includes a social worker, psychologists, peer navigators, and myself and Vanya as clinical individuals working on the project. There was such great demand from AGIA and from the clients they were working with that we started the project before we in fact had the money in the bank. We had an advance from the CIUS for us to start the project, and we started seeing a lot of young people who wanted primarily to transition. Most of those individuals come from the Middle East or Africa, and as you may or may not know, these are countries where there are important laws in place against the human right, which attack the human rights of these individuals, leading to imprisonment, leading to sanctioned or turning of a blind eye to essentially attacks on all of these individuals that are abusive and can be quite remarkably abusive in what they're doing and what they do to these individuals. In fact, I've been completely overwhelmed by some of the things that occur with some of them and to them. So we then started doing this work and seeing this population, and we've in fact since September have gotten 70 to 80 contacts, not essentially all of them related to medical aspects, but related to a variety of other aspects that are related to food deprivation or lodging issues, or a variety of other social issues that have just been made worse by COVID, because people are not only seeking some places to live and food and cannot work, and if they are working, frequently they end up in situations where they are selling sex for money and or food or lodging, and therefore put themselves in very difficult situation. They are also very isolated, and even more now with COVID, so it makes it very difficult for us to reach out to them. Hence the use of the peer navigators who speak their language, who come from the similar background that they come from, and are able to then establish a closer communication than we can. Clearly, I haven't learned Arab in the last few months, so it makes life a little bit more difficult. And nor have I learned Spanish. So that's one of the big problems that we have, and which led to some of the issues and difficulties that I've had in dealing with this population and understanding how to manage this population. They clearly are coming from a environment which is very different from us, both point of view of their experience, but also point of view of their medical culture and the way that they function and the way that they perceive the family physician and the role of the family physician. Essentially, the family physician is seen as somebody who orders tests or who essentially refers them out to more aggressive treatment. Every problem has to be, in their mind, investigated to the utmost. And I have a direct connection to MRI, though I try to divert them from that. They also expect surgeons and people to do surgery and to fix things, and are not really necessarily always ready to put up with a more conservative approach. So that has made dealing with this population a little bit more difficult. Plus, the other thing that occurred at the beginning is that we were using the peer educators, which was very helpful, to translate it. But I not quickly, took me a while to sort of understand that the peer navigators were coming with a baggage of their own. They had experiences of their own, that had lived experiences, and they would translate. But frequently, I would be sitting there and watching the interaction while they were speaking, and there clearly was a lot more talking than there was a translating. And so I came to realize that what was happening was probably that they, young people who were our peer navigators, were in fact interpreting, not meaning translating, but they were interpreting the what the patients were saying through their own experiences and their own lived experiences, so that I was getting a mixture of things, which was both what the patient was saying, and both, I think, what the lived experience was of the interpreter or the peer navigator. And I came to realize that most recently when one of our peer navigators has been off for medical care, and so we had to use professional translator. And I saw that there was quite a difference between using the the professional translators and the peer navigators. It was a lot, shall I say, drier, but at the same time, it seemed to be a lot more accurate, and I would be able to get more information and was able to keep them more on track in trying to figure out what was happening and what their issues were. Yes, many of them are transitioning, and that in itself is not an issue for me, but they have some multiple problems, medical problems, and it's been hard to try to tease what those are, because frequently we will be going all over the place, especially when the peer navigators are involved. So that's been the sort of the difficult aspect. of sort of dealing with the population. The sort of positive thing is that, in fact, we've had lots of support from a variety of organizations who have provided us with extra funding to hire more individuals, so more peer navigators, and to be able to continue the project until June, until we then see whether or not we get a further grant from the college or other fundings of some other form, to ultimately open an equivalent to the Maison Bleue, which would include and integrate AGIA, which is the community organization, with a clinic within it where people would be offering services. So that's as brief as I can make it.
Thank you so much. That's really fascinating and interesting how this really comes from community initiatives and community desires and needs that have been expressed, and how the health system can try to adapt and reorient itself very much along the lines of the Ottawa Charter, to be able to provide this care in a way that that community members find is appropriate, is safe, is also close to where they are, and so forth. So all of these things being so important. I'll turn now to Dr. Cherwin, who's been working for many years trying to meet the needs of specific population in the CLSC Park Extension neighborhood. So perhaps, Dr. Cherwin, you could tell us a bit about your trajectory and how this brought you to create a sort of special service. And I know you've also done a lot of outreach work, even with schools and other community organizations. So maybe you could tell us a bit about how you got involved in that beyond the clinic doors. Thank you.
Hi, thanks, Anne. And thank you for Dr. Talier for describing your clinic. I can see a lot of parallels with, I guess, any healthcare provider that's trying to identify a target population that has specific issues that need assistance. And so this makes me think of the asylum seekers, who are part of the people that I have seen at in Park Extension, along with generally just immigrants who are settling into a new life in Canada. I would say that we have to remember that we're talking about asylum seekers. The synonym would be refugee claimants. And just remind people not to make the mistake of confusing a refugee claimant with a refugee. The main difference being the very personal suffering that an asylum seeker or refugee claimant has to go through, of being in limbo for a period which can last anywhere from, even with COVID or before COVID, anywhere from 2 years to 4 years to longer. And many of the people that I've met are separated from some of their family, so their own children who have been left behind in the home country. So asylum seekers, to put it into context, I always thought that I was dealing with a population that was less than 1% in the city of Montreal. So I looked up some statistics and actually a document that was sent to me, because statistics are really hard to find. And in 2018, 27,000 new asylum seekers came to Montreal. And then I divided that by the population of Montreal, which was over 4 million. And that gave like 0.64% of the population of the city. So a very small population that, and I'm sure in Park Extension it's even lower than that. But the thing is that in my neighborhood, the proportions of people who are asylum seekers is much higher. So that in my practice and in the people that come to CLSC Park Extension to get services, the asylum seeker actually represents a much higher percentage. And I had to think of all that because I wanted to justify the amount of effort that I'm putting into providing services to asylum seekers. And I would say that I've tried to be innovative, but really it was a question of trying to provide an entry point for an asylum seeker who comes to a medical system that is completely foreign to them. And from data that I've been looking at in my own practice, 30% of the families that would settle into Park Extension were never properly oriented to the medical system not even to the legal system, which is going to be essential to them to hopefully succeed in becoming a permanent resident of Canada. So because they don't know the medical system, in Park Extension, the other issue is that there is an underground problem of, we can call it human trafficking, we can call it natural human migration in a world that is completely changing because of things like war, climate change, and so on. And so in Park Extension, many of the asylum seekers have been directed as to how they should speak and how they should act. And with regards to the medical system, they have been specifically told, you must go out and seek a family doctor, because the family doctor will help you succeed in getting your claim for permanent residency. And so that colors everything that I do. In the last 10 years, our site became a family medicine teaching unit at the same time that we became a family medicine group. So we became a GMF and a family medicine unit in just the last 10 years. And I was hoping that with so many new trainees, residents, that they would be able to absorb the number of asylum seekers that lived in the community that did not have family doctors. But unfortunately, as we see, all the services that we provide can very quickly be saturated. So by October 2018, my team, myself included, decided that our walk-in clinic would now only accept people who are registered to the family medicine group or the GMF. I voted for that too, and I felt that there was an issue of cultural safety, because it was beginning to become very difficult to have an asylum seeker break down in a walk-in clinic in front of a medical student or a trainee, saying that they had been beaten by police or raped by police, and they didn't have a doctor and they needed someone to help them. And so this was the kind of issue that we would see in the walk-in clinic. And I thought this is not a good place for us to address such a complex situation. So I agreed with my colleagues that we had to close the walk-in clinic, not only to asylum seekers, but to all new patients that were trying to find a family doctor, because we always had like 6 spots in the morning of our walk-in clinic open to asylum seekers or open to people that were not registered to the GMF. So we stopped that in October 2018, and that was my innovation, was that I would then have a clinic where I would specifically target asylum seekers, try and find out who they were, because again, there are no statistics. So I don't know how many asylum seekers live in Park Extension or who they are. And so it would be quite challenging to identify them and then tell them, look, I'm opening up spots where I can see you and give you a full hour. And I will use this time to offer you, and this is the other innovation, not prise en charge, which means continuity of care, which is one of the pillars of family medicine, but instead I will offer you recommended screening tests for immigrants, for the adults and for the children. I will plug you into all of those programs and services that are provided and to which you're entitled in the CLSC. And I will hook you up with any services that I can think of that I think are appropriate for you. And you can also tell me what you think is appropriate. But the idea would be not to become their family doctor, which in truth, many of the asylum seekers were very sad to hear, because they all were hoping that I was going to become their family doctor. So I had to disappoint many of them, but I was able to see about 82 between 2018 and 2019. And then up until recently, I've seen another 126, and I've kept basic data. And some of that data showed that many of them did not even recognize that they had social workers that were experts in asylum seeking care under the organization of PRIDA. So 30% of the people that I would see did not know that PRIDA existed, and they never got the proper orientation or information about how to get a lawyer, and to realize that they would have to basically represent themselves in front of Immigration Canada. So a lot of people are realizing this for the very first time. And my clinic, the innovation is that it's an opportunity for them to say, this is what I know, and this is what I don't know, and what can you do to help me? unfortunately, you're looking at the only person of the clinic. So I didn't unfortunately get any funding. I didn't get any institutional support, but I'm in a CLSC. So all the services there are available to me, and I just have to connect the asylum seekers to it. So I would say that my innovation is maybe not very sustainable. And I am looking with the community organizations and with other partners in the community in how to make it work better.
Thank you so much. So to me, it's fascinating to see these two innovations. And before we go to questions, so start thinking about all your questions, and maybe I'll just reflect for a minute on the experience we had between St. Mary's Hospital and Multicaf, and some of the similarities in terms of different themes and maybe some of the differences as well. So one of the themes I'll pick up on is the appropriateness of this in terms of resident teaching, medical student teaching, and so forth. For the Multicaf experience, it actually originated, and I can see some of the students are actually on this call with research projects looking at, who is living in the community that we serve, what are the challenges facing people in our community, going outside the clinic walls and the hospital doors to see what are the different needs of the population that we serve. And this actually led to this reflection that actually led us to start this outreach clinic at Multicaf, and also the desire raised by the community organization. So similar to Dr. Talier, the community organization saying, we have a need. Our clients are coming in and they're expressing that they're not connected with family medicine, with a patient medical home, and they want to be connected because they have needs that are not being met. And I think many times these residents, got the Resident Research Prize and so forth, really for opening the eyes of people to some of the things happening in Côte-des-Neiges. Like, we were not aware the extent of hidden homelessness, for instance, in Côte-des-Neiges, or even that there's forced marriages in Côte-des-Neiges. These were all things that came up in the discussions that people had with community organization representatives, with people living in the community. So it was a real eye-opener. And the process of setting up this clinic was really a desire so that it wouldn't all just be a one-person thing and dependent on one person, but really trying to integrate it into St. Mary's and also give each resident an opportunity to be matched to one of the patients and follow them longitudinally, which actually was happening. So it wasn't so much an outreach as an onboarding. So we would identify people in the community, and the community organizations would refer people, and then we would make the link, and then they would be followed in the family medicine group and registered and so forth. As a result, we actually, so here's the theme on asylum seekers, is that we required that they have a RAMQ card so that we could open the electronic medical record. And we actually had the computers outside the hospital, which in itself was a whole to-do to get that organized so that they could use MILE, the electronic medical record, from the outset. And therefore the RAMQ needed to be provided to us in advance so that we could open the electronic medical record and not have papers flying about and residents having to bring the paper back and do entry afterwards and so on. And there were some people who didn't have a RAMQ card, someone who was, for instance, homeless, and then they would try to get it through the community organization, which could be their address and so on. For refugees and asylum seekers, it was sort of my next hope that we would try to organize through St. Mary's that every physician gets registered with Blue Cross, so that at least that the asylum seekers who are refugees claimants under the interim federal health program could at least have remuneration and so forth. And when we had done together several years ago a refugee CPD activity, I recall that one of the ways that PRIDA through the CLSC Côte-des-Neiges is organized is that they actually have this set up so that it can be a sustainable thing. People are working together and they're just being paid by the IFHP rather than RAMQ. And in fact, some services like psychology counseling through different organizations that are available in Montreal are actually paid for, which might not be paid for some of our other groups, for instance. One of the challenges we came across was also when we started having certain patients, and you were mentioning about this, safety of residents and students breaking down and so forth. So this was also a concern that I had, because we want to make it a safe learning environment. And sometimes people have been through, one patient in particular was hospitalized 10 years at Institut Pinel and was then in the community, but it was not clear what kind of follow-up this person has, but he rolled into the community organization and didn't have a family doctor. But was that appropriate for this? And so I needed to intervene, and I was always the clinical supervisor there. So I think you raise a lot of questions and challenges about how do we ensure this, the good learning experience, a better service for people who are disconnected from a patient medical home, and also how do we orchestrate some of the administrative side of things as well, which are also really key. And just as sort of a bit of a sad ending to our clinic is that when COVID hit in March, the community organizations shut down. We had to cancel some of our last planned clinics for 2020. And one of our key community organization, let's say champions, also left the organization. And so that made it also very difficult to then continue, and with all the remote learning and so forth. But I'm hopeful that perhaps once things settle down, we could find maybe a different model for doing the onboarding, but it was still something very innovative. And so again, the sustainability. So I'm going to open the floor, and maybe we'll take a few questions at a time and then allow a round of questions, and that Dr. Talier and Dr. Cherwin can address the questions that you have. You could put your name in the chat box, or you could raise your hand. Let's open it up to the audience to hear some of the questions that you have about how we can have better systems of care for different groups within communities.
And just to point out, there's a couple of questions already in the chat. Would you like me to read, or do you want to?
Yeah, if you go ahead, please. Mm-hmm.
Okay. So I'm trying to figure out where to start. So there's a very nice provocative one here from Yasmin. So let's go ahead with that. So are human rights universal? And in what contexts are we imposing Western values onto people from different backgrounds? And coming from a top-down approach versus when we are advocating as a global moral imperative as health professionals. So how's that for a sweeping question to start? And I'll turn it back to you. You can pick on the panel as you like.
Sure. Well, maybe I'll read one other, and then we have one other question from Tal, and then we'll let, after this round of questions, we'll let Dr. Talier and Dr. Cherwin respond. So the other question that I see is about measurement. So how do we measure and collect data on underrepresented and underserved populations? Also, what degree do medical professionals collaborate with the legal sector? For instance, the asylum seekers who have to represent themselves, but what happens when actually they don't pass their hearings and they're being told that they have to return to their home country? In fact, we had a lawyer who used to teach the medical students, and that was his main work. Dr. Evans is asking, what sort of linguistic, cultural, and legal competencies should be introduced into health professional training to enhance more effective linkages to these communities? And we'll take one last question from Tal, and then we'll hand it over to Dr. Talier and Dr. Cherwin to address those questions. Tal?
Thank you so much to all the speakers. I'm really inspired by the work that you do. I actually started an asylum seeker clinic, a free student-run clinic in Haifa, working mostly with the Middle Eastern population and the LGBTQ+ population. So I'm really inspired by Dr. Talier's work. And my question is, how can health professionals and researchers be allies to this population? And I'll be working in the US, so I know it's a different community, but how can I or healthcare workers be an ally to asylum seekers in the US?
So maybe we'll let Dr. Talier, would you like to go first?
Okay, maybe I'll answer the last question. There is a group that exists in the US, actually through at least adolescent medicine, which arose as a result of the Trump policy with the children that were trying to or came across and putting them in detention centers. Not that Biden has changed much of that, but he's sort of modified it a little bit. And that group, and I don't remember what it's called. I was joined into that group, but and I get their emails. But physician groups do organize themselves and do exist in the States to not only provide, but primarily to advocate for this population and to advocate for services for better treatment of, at least in the group that I'm dealing with for youth, children, and adolescents. So they do occur, and I could send you the link to that particular group when it comes up in my screen so that I can remember it. But in the States, they do exist, and they've been at work for some times now. They've also written, in conjunction with other medical organizations, of a variety of advocacy policies when things have come up, not only around migrant children and asylum-seeking children, but also around GLBTQ issues around the States. And I was involved in writing one of the advocacy pieces, facilitating it. I didn't write it because I'm not from the States, so we wanted somebody from the States to write it. So they do exist, I know, from the adolescent medicine perspective, and I'm sure it exists from other perspectives as well. The one thing that did come up, point of view of the legal aspect, and I'm just not going to try to approach everything, but or deal with everything. The legal aspect, the place that I saw this work best for me was, in fact, when I worked at Head and Hands. From the creation and implementation of Head and Hands, now a little over 50 years ago, what happened is that lawyers were included in it was a community sort of outreach response. It was created by Head and Hands, was originally an outreach program from the YMCA and then taken over by the community, of which lawyers were part of that group. And so what happened is they ran a legal clinic at Head and Hands twice a week for free, so that we could consult if I needed. And it happened to be on the nights that I worked as a physician there. If I needed some help, I could just walk down the hallway or down the stairs and speak to them and ask for an opinion and ask for some help, which made it easy because it made it more of a team-like approach. So it added a different member to that team, which was useful at time around a variety of issues, because they can be helpful when they're trying to get their immigration status, but so many of them are abused, and so many of them are in abusive relationships and need advice around those things and how to manage those things. And that was helpful to have that assistance there. Point of view of human rights, the human rights data that I've gotten and use has come from Human Rights Watch, which is in fact, again, a community organization that looks at what's happening in various countries. And it doesn't only include the countries which we identify as being, major human rights, sort of people who abuse human rights. So, not only Russia or the Middle East, but they look at Canada. And for example, they look at how we deal with Indigenous populations. And that's written up in that report. They clearly looked at the US as well, and some of the European country, and how they manage their migrant population and people who are seeking asylum. So they look at every aspect of respecting the human rights according to the WHO and the UN. Understanding the Charter of Human Rights is something that supposedly all the countries who are members of the UN sign upon. But there's a disclaimer that the local laws and local customs will supersede what is in the human rights code. The other, which is not particularly helpful for some individuals. So there is a group of lawyers and other human rights advocates that have come together, that have formed a group that also advocates for essentially the respect of the human rights code of the UN, and that's the, I can never remember how to pronounce this, the Yogyakarta Charter, and they advocate for much more stringent implementation of the human rights code of the, or charter of the UN. But it is important to understand that despite the fact that these are things that are maybe coming from the top down, that these are very basic rights. It's the ability to access care. I mean, in some of these countries, people can't access care, especially GLBTQ individuals, basically because if they go see a physician, frequently the physicians will divulge their information and will report them to authorities so that they are afraid and anxious to seek care. And one of my colleagues last week, when I presented at the CLSC on the program that we're doing, said one of the things that is very important, as it is with any of our patients, is that we need to define confidentiality for them and how we will respect confidentiality as a basic step. So I'll just stop there.
Great, thank you so much. Yes, a lot of questions, and perhaps now we'll hear from Dr. Cherwin. Maybe I'll just read out this one additional question that's come in as well. So Anish, I don't know if you want to say it, Anish, or you want me to read it out. Maybe you would like to speak.
Don't mind. I guess it's kind of a long-winded question, and I don't think there's going to be an answer from this, but I was just sharing that in the last few years, I've been working very closely with migrant people living with HIV, particularly at the RI-MUHC and the MUHC. And what we see is that, these fundamental individual level barriers that exist, the moment they, come to OECD countries, not just Canada, USA, Australia, any of these big name countries, what we see is that they have this massive sense of fear of stigmatization, fear of not being treated fairly, fear of deportation, particularly if they have an undocumented status. All of these issues prevent them from even stepping foot into the clinic. Forget lack of knowledge about the system, forget not being able to navigate the system. Just the idea of them being pushed away from Canada or pushed away from that safe haven that they finally met or reached to. And so one of the questions I've been thinking a lot about is how do we get these migrants to, at the early, initially, before they even, get HIV into the clinic? What are things that we can do to help mitigate that barrier, that fear? Because, and it's not just fear. I mean, language is one thing you all mentioned. The lack of knowledge about navigating the system. How do we get these interim federal health examiners to better link these people? What can we do to better support these people the moment they come into Canada? And I don't know what the best thing to do is, and that's why I'm asking this question, but I also don't know if, I don't know, just some thoughts.
So I'll turn it over to Dr. Cherwin. Sorry, go ahead, Dr. Talier.
The important thing to remember is that these people are not the only ones who are fearing access to medical care. It has been demonstrated in multiple research that the GLBTQ plus population is not necessarily very well treated by physicians, and many physicians have biases and have prejudices of their own, and that is felt by the population, and this population specifically, and they don't seek care. Why? Then this is why a lot of them have chronic medical problems that are not being treated or addressed, acute problems that don't get addressed, and issues around mental health that don't get addressed. And they are the highest incidence of any of the groups within at least Canada and the US. So suicide rate, for example, amongst trans individuals is extremely high, and the highest that exists of any group. And abuse. I mean, we have, many of you may have seen what was happening or what happened in the subway in Montreal over the weekend, if you were watching the news. And so this is somebody who is seeking asylum, who goes into a subway. I'm not quite sure how it led to this, but essentially is attacked by the authorities. The person will not feel welcome. The person will not feel like they're in a safe place at that point. So it's important that we remember that we are not perfect.
Before I turn over to Dr. Cherwin, I'll just read, there's a couple other comments. Alex McComber also writes that that this is also something that many Indigenous people share as well. And there have been reports written on this. Also, Dr. Janet Smiley, First Peoples, Second Class Care, is a report that had come out a couple of years ago. I would also say that many of the people with mental health issues, also not always very easy to access care. And in our clinic at Multicaf, there were many, many people who had undiagnosed diabetes, quite advanced, and many different reasons why they weren't and these were people with a RAMQ card who also weren't accessing services. So we definitely can do better, and reorienting the health systems is one key. So what can we learn about these different experiments in reorienting? So I'll let Dr. Cherwin continue in terms of answering whichever of the questions he would like to talk to.
Thank you, Anne. This is a great forum where people can share in discussion and share views, where it's never a right or wrong answer, and there's a lot of gray. And it's great to be part of an educational system that also deals with healthcare and mental health, so that we can talk about these things without fear of recrimination. So thank you for this opportunity. I'll try and answer the questions a little bit all connected together in a segue as much as I can. In terms of Anish's question about how can we introduce the proper information at the appropriate time, my answer will be in what I have seen with asylum seekers from the North Indian Punjab in India, which is the majority of asylum seekers in Park Extension. They're the biggest group. What happens in this global reality of human migration or forced displacement, or whatever you want to call it, is that they arrive mostly to the airport, following strict instructions of where to get off, where to get on, and then where to claim asylum. This is part of the seeking of asylum. It's part of it. Just like people going to the US-Mexico border have been given instructions on what to do, and they're all expecting their human rights to be respected. And so they're aghast, like the rest of us watching on TV, when people are turned away, when people are put in cages, when the basic human right that where you have the right to request asylum is being refused. So for the people that I see, the ideal spot would be at the airport, where they make the claim for asylum. And usually they do get a document. Now, some of them might refuse other information that's being provided to them, such as PRIDA is an organization that can give you information. Here's their card, please contact them. Some of them are under strict instruction not to do that. and instead to get into a car with somebody else who knows them in the community and drive them into the community, and there it's game over. That person is not going to get the official information. But fortunately, there are people who do go to the temporary housing at the YMCA, which is linked to PRIDA. And then I think most of the people go that route, and they do get the right information. So what do we do with the people that don't get the information? That's where I'm hoping that my asylum screening clinic will be making a little bit of headway in trying to reach out to those people that were not given the information from the get-go. There is fear, for sure there is fear. Whether you're LGBT, whether you're living on the street and you're homeless, whether you're an asylum seeker, there's always fear that you're going to be targeted, discriminated, hurt, deported, whatever, killed. So the fear is always there. I'm going to tie it to the other question of, how do we become allies of the asylum seeker or the people that help asylum seekers? You become an ally by basically thinking of whether you're in an ivory tower and thinking of whether you should just walk out of your institution and walk down the street and go to where the community organizations are. Now with COVID, of course, that one silver lining is that it's brought people together. So in Parc Extension, our institution, which is our CIUS Centre-Ouest de l'Île, they have their representatives who are meeting in Zoom with community organizations. And these meetings happen twice or once a month. And it's an opportunity to meet with the organizations and talk about the issues of food distribution to people who are going through quarantine during COVID, of what to do with people who don't know if they should get tested or where to get tested, or who have questions about vaccines. So different community organizations with different specialties come together with the institutions, sometimes also with people from the police, people have to do with housing, and we all talk about the problems. And it's a long ordre du jour. It takes a long time, but you become an ally of the target population that you are trying to help by going out and making links with the community organizations. And some of them are larger than others. Some of them have citywide representation. Others are tiny and just exist in your neighborhood. But even though they're tiny, they might be very relevant for the people in your neighborhood that are too scared to learn how to use the metro or how to use a bus to get to some other service which is too far away. In terms of competencies and teaching, the linguistic, legal, cultural competencies and teaching, I can tell you that one of the innovations was because of McGill University and the medical students. They're obliged through their curriculum to do what is in their second year of medical school, the CHAP, the Community Health Alliance Project. They're supposed to be introduced into the community. They're supposed to visit different community organizations, learn about population health effects and various socioeconomic issues that affect health. And so before COVID, they were going to meet all these organizations. Then COVID hit. So at that time, with the medical students, we had been trying to develop a clinic for asylum seekers at our CLSC, where we were trying to have interdisciplinary services provided by social service students, dietetic students, nursing, and the medical students, of course. And we wanted to actually run an asylum seeking clinic out of the CLSC. Unfortunately, we didn't get buy-in from the institutions, neither our CIUS nor McGill, probably because of technicalities of there's so many different disciplines represented. At what level of training are they? Can they actually meet patients? Are they going to be sufficiently trained? Will confidentiality be respected? All of these issues. But from that, what has happened, even though we didn't get buy-in and we weren't able to launch our clinic the way we hoped it could be, the medical students went on ahead with other students from McGill, and they're doing these health navigation clinics where through telephone, because it's all through virtual, they do meet asylum seekers, they do provide them information, and they try and plug them into the different points of the health and social service system of Montreal. And they've been doing these sessions with asylum seekers, and I am assuming also with other status of migrants. And I think it's been successful. There has to be a follow-up. But this is the foundation of something that I think is going to grow. In terms of linkages with, connections with the legal system, I really like Dr. Talier's idea of there being a legal clinic within a clinic that's running, or institution that's running a health or social service kind of clinic, then also having lawyers there present. It makes sense, like a one-stop place for everything. But for asylum seekers, what PRIDA tries to do is mainly tell them about aide juridique. So telling asylum seekers that they have access to free lawyers, that they don't have to pay these thousands or 5,000 exorbitant fees. If they don't want to, they do have an option. So aide juridique is introduced to asylum seekers mostly through PRIDA. If I meet a patient, an asylum seeker, I will give them flyers to tell them about PRIDA, and telling them specifically, if you have any questions or concerns about your legal situation, do go and speak with PRIDA. Although there is that fear, and maybe some of them have been told not to go to PRIDA because that would create more problems for them in the government. Because that's what a lot of the human handlers or the human traffickers in Park Extension are doing, is they're spreading misinformation so that they can make a profit from the asylum seekers. The question on the universal human rights, I looked at it quickly, so I might not be totally understanding it, but for me, universal human rights is just that, it's universal. I think that there is definitely always the risk of sort of imperialism and colonialism and top down and telling other countries how things should be done. But we have seen how even very advanced and well-to-do countries have been breaking the basic charter of human rights again and again. And we have been doing it also in Canada. And people brought up the indigenous people and all the issues that they've gone through. So obviously we have a history, and obviously we can do much wrong if we are not careful. But as far as I'm concerned, universal human rights should not be top down. It should just be applied everywhere. But unfortunately, in the global arena, we don't see this. Usually people are accused of human rights, or nations are accused of human rights when there are publicly accepted enemies. So if there are enemies, then we can accuse other countries of being violators. But if there are allies, we usually sort of just, we keep quiet. So I think universal human rights should be universal for sure. And I think we have a lot to catch up in, because the last 4 years have been a degradation of human rights. And part of that is going to lead to more human migration, more forced displacement. And you can be sure with this pandemic and with global change and everything, the climate change, that there's going to be a lot of pressures. I don't think our health systems alone can do it. So that's why we do have to link up with the civil society so that they can help us, because there isn't going to be one vaccine or one pill that's going to fix all of these problems.
So I see that our time has whizzed by, and we're now actually at 1 minute past 1. So I think, unfortunately, we're going to have to wrap this session up, but I want to close perhaps with the question that Dr. Evans highlighted here, which is, has the cost of inadequate health and social action with respect to these diverse constituencies been aggregated in such a way to present policymakers and research governors with arguments as to why more needs to be done? And I guess that is really the crux, that what I hear from Dr. Talier and Dr. Cherwin, and what I know also from my own experience working at the CLSC Côte des Neiges, is that those who are caring for these people are really stretched very thin. And it would be great if we had a graduate student or a postdoc or a social science graduate student, or somebody who wanted to aggregate all this data and package it in such a way that it could help those doing advocacy for these marginalized groups to present it to policymakers and obtain better services. And that is not to neglect or deny the advocacy role of physicians, but I think in this case, given the massive needs of these communities, that we probably do need some help here. So on that note, I want to thank Anne Anderman very much for your moderation of this session. I want to thank Dr. Talier and Dr. Cherwin, very much for your very thought-provoking and insightful and heartbreaking in some ways comments and vignettes and insights into these communities. And thanks to all the participants. We had close to 40 people here, so that was great. And everybody, please come again next month. Keep connected on the social media and you'll see the dates, but I believe the next session is the middle of May. So look forward to seeing you all again, and thank you very much.
Thank you.